Good afternoon, respected seniors and dear friends. I am feeling overwhelmed actually to start this second episode of the monthly webinar of Government Medical College Amritsar. As the head of the department, it is a pleasure to start this chain of webinars to increase the academic activity so that we can have some expert speakers and also to introduce our young alumni to the world of academics and e-learning. As a part of the program, I'm happy to introduce that this is a 100-year-old medical college with a great legacy and wonderful contribution to pediatrics as a subject, because all the legions of pediatrics started their journey from Amritsar, like Dr. Meherban Singh, Dr. S.S. Manchanda, and many more. And to my much delight, it is a pleasure that today we have a speaker who is par excellence. If you talk about development, I think it is equal to M.K.C. Nair, sir. And I'm so happy that one of our proud alumni, Dr. Inder Manjot Singh, who post graduated from our own college a few years back, who is also heading the district hospital at Sangrur and is doing wonderful job, is going to moderate this session.
Thank
I'm
you.
actually happy at both ends. Over to you, Inder Manjot, to introduce the speaker. I think there are no words to introduce this speaker, but you can definitely try.
Yeah, you are absolutely right. When I was reading about Sir, it's like you get overwhelmed. How much a person can achieve in his lifetime? Sir has done, I think one can need 3, 4 lives to accomplish that much. And reading his introduction is so encouraging that you feel that you have done nothing in your life. You need to do lot and lots more. And as I was watching Sir's video, and Sir doesn't look that old also. Sir looks very young. So it's very encouraging that we are able to hear him today. And it's lucky that I have got the opportunity to introduce him. Uh, Good afternoon to all my seniors and respected seniors and juniors. Today, as we know that it is second in a series that ma'am has started, Paediatrics Unplugged. Today topic, as we all know, is autism spectrum disorder, a relook, which is very much relevant in these times. After COVID, as you may all know, that in our OPDs, there is a quite surge up in patients that are having autism spectrum disorders. Patients daily come to us uh, with different complaints, as we all know. Sometimes babies are hyperactive and parents are worried. Sometimes he's lonely playing games alone and not showing interest in anything. So these cases are jumped up, maybe due to screen time and many more things. So today, I'm quite sure after this talk, your dilemma will be solved. As what I have felt in my days, in my OPD, I will share with you. It's quite a challenge to diagnose and treat them properly. More times, parents do feel that their baby is normal. Like in Punjabi, they say, "ये चौड़ करदा जी," या in Hindi, patient say, "थोड़ा शरारती है बच्चा." Sir, शरारती है, but it's very difficult to make them understand that your child is not a normal child. He might be having a autism and ADHD. So it's really a dilemma how to make them understand the diagnosis. And moreover, when you are not yourself confident, then it's become a huge burden how to make them understand when you are not yourself confident. So I'm quite sure that after this talk, you will be able to diagnose them properly and handle the cases accurately. It's my privilege to introduce such a huge personality. Uh, Dr. M.K.C. Nair, his name needs no introduction in the field of pediatrics. He's a true leader in both his vision and actions. A visionary in developmental and adolescent pediatrics, he has been at the forefront of child health innovations in India over 4 decades. Child Development Center was his dream, which is now considered a national asset for research Child Development Center, which is now considered a national asset for research, training in child and adolescent development, with 25 years of follow-up of low birth weight babies, leading to the award of first Doctor of Science degree to any medical person in 80 years of history of a University of Kerala. As the founder director of Child Development Center in Thiruvananthapuram and former Vice Chancellor of Kerala University of Health Sciences, Sir's contribution have shaped early intervention and pediatric education across the country. He has over 176 national and international research papers and 22 medical books as author, editor, and is widely recognized for developing screening tools like the Trivandrum Development Screening Chart, which is now a part of RBSK. He has been elected Fellow National Academy of Medical Sciences in year 2020. Currently working as a director, NIMS Spectrum Child Development Research Center, Thiruvananthapuram. Sir has been nominated as a governing body member for Noor Islam Center for Higher Education, CDC Thiruvananthapuram, National Institute for Physical and Medical and Rehabilitation Center, Thrissur, Kerala, National Institute for Speech and Hearing, Thiruvananthapuram, Institute of Health and Management, Bangalore. Professor Sir is a national authority in developmental and adolescent pediatrics. And annual conference of both bodies have oration on his name. Today we are fortunate to hear him speak on the topic that demands both clinical precision and compassionate insight. Autism spectrum disorder, a relook. Depth of experience will surely offer us a fresh clinical insight, updated approaches to early identification, and reflections on evolving diagnostic frameworks. This talk promises to be an invaluable opportunity for clinicians seeking to deepen their understanding of ASD in today's context. Please join me in warmly welcoming Professor Dr. M.K.C. Nair.
Can I do the screen sharing?
Sure, sir. Sure, sir. Jyoti, can you just help out with this? And I
Then
would
because
request all the
sharing is not
delegates.
turned on. So
No, sir.
Yeah, turned on.
It turned on, sir. You can share now. I request all the delegates to put their questions in the question and answer so that we can take them up at the end of the session.
Yes, sir. Visible, sir.
okay. So good evening to all. When I am talking to a crowd basically from Punjab, particularly Amritsar, I cannot forget to mention name of Dr. S.S. Manchanda, who was my examiner in 1979 at PGI, Chandigarh. Although I was a student of Sheila Singh Paul and Manorama Verma at CMC Ludhiana. So that was a great 10 years of Punjabi culture, Punjabi food, and Punjabi behavior, which of course has gone away now, become very sober. The concept of Child Development Center I had developed in CMC. So as a postgraduate, I first dreamt of having the Child Development Center when I came here, started with a child guidance clinic, and 1987, sorry, yes, 87. 1st of August, we started the Child Development Center project, and whatever I'm here seeing today is from that. If you ask me, have you made any contribution to pediatrics in India? Apart from the IAP textbook of pediatrics, it is 5,000, more than 5,000 doctors, pediatricians who have been trained, certified in developmental pediatrics or adolescent pediatrics. So let me get to the subject. Let me start with the latest thing. Autism we will come to, but 1 or 2 slides on what is important for all pediatricians. The first 1,000 days of life. If pediatricians have to survive, now it is not enough to talk about nutrition, malnutrition, and all that. We realize we should talk about infection, emerging infections. Now we are come to newborn, we are coming to perinatology. So the first 1,000 days is 270 days of intrauterine perinatal part, next 1 year, second year. Because by second year, the brain development is almost 85% over. So that is the first 1,000 days. I won't talk more about it. You must also remember one concept, habilitation. Unfortunately, we have been talking about rehabilitation. We wait for an impairment to become disability and then start doing. And you say it is early intervention. What is so early about it? It is not early because already disability has happened, and then you do to prevent handicap. What we should be doing is we should be doing everything with impairment stage so that it will not go into disability. And what are the two causes? The low birth weight and extreme prematurity. I was just reviewing what happens to these babies after at adolescent, young adults, even adults. Most of the problems. I'm not talking not only talking about the Barker hypothesis, which I proved and got my DSc. I'm talking about all mental health other things. If you trace back to what happened to them, it is either low birth weight or extreme prematurity. I think that is the message we must go with today. Rehabilitation, of course, where all the therapies come into picture, not only the pediatrician, not only the development therapist. Development therapist is the person who assists pediatrician to prevent neurodevelopment disability. And this is the one slide I think you should look at it. I'll show in every talk because it's important. We all talk about obvious disability and handicap. And I must say, even my, PG days, Dr. Manorama Verma, who used to talk about some of these issues. Although she was not a neonatologist per se, but always she used to emphasize that we should do things early. And what is that early? If you have a disability, what are you going to do? Very little. But if you pick up below 6 years, development delay, communication delay, language delay, motor delay, and 10 neurodevelopment disabilities, then we can do a lot. The global development delay is there, which of course mainly may go into developmental disability, particularly intellectual disability disorder. That is, after 5 years, they usually become intellectual disability disorder. Not all, but a good number of them. Now let's come to autism. Autism, what are the concerns? I just ask questions and give answers. Is the incidence, is it increasing or just recognition? You know, there are many reasons for increase. Everybody knows it is increasing. One may be, we may say it is because we are recognizing more. It is because all MR, mental retardation, all have become now autism. It may be because we have a spectrum disorder, so a lot more has come into the picture. Whatever explanation you may say, that is correct. But having said that, we have enough evidence to show that actually autism spectrum disorder prevalence is increasing. No doubt about it. Plenty of data on that. Now, second one, what is the causation? We talk a lot about genetic and environmental, but the most important is actually environmental. Genetics is there, good part. In individual cases, genetics is important, but the majority of cases, it is the environmental, and that is why we have, in the autism time, we had a lot of increase. Three things which has been proved. My assistant, who was a next director of CDC, Dr. Babu Jodh, PhD thesis was that if you do not have, of course, first, of course, is mobile phone. Mobile addiction to mobile is a number one cause, as has been shown in the COVID time. Number one cause. There's nothing else. You remove that, lot of things will go away. But second most important one is that if you have do not have children of the same age to play with, 20 times more chance. The odds ratio is 9.7 or something, which means 20 times more chance. If you don't take the children out, you know, to meet other people, play, open ground and all that. Instead of if you look up, you see the white ceiling. If you look side, you see the ceiling, nothing more to see. Child will get autism. And the third most important is you don't sit with the baby, show them, help them to do the drawing, talk to them, give them simple lessons. So that these are important. So what as we realize is, fortunately, the autism actually government of India 50 years ago has done something for preventing autism, and that is the ICDS Anganwadis. That's the only place where you get free of cost children of the same age to play. Okay? Why don't we use it? I'm referring more children to Anganwadis than any other places because there you get similar age children to play with, and they all do action song. Action song means you see, you hear, and you do. Children can learn so much. Socialization occurs. Autism has 3 problems. Number 1, communication is affected. Don't say speech is affected. Speech will take long time to come. Communication is affected. Number, socialization is affected. The child tend to be in his own world. He'll be doing lot of things. Mother think he is sitting and playing, but actually he is doing, just nonsense. It is not a purposeful play. So that is the most important. Then, of course, parenting, communication, socialization by this one, excessive mobile use. TV may not be so bad as compared to mobile. And enough studies on showing effectiveness of early intervention program. In fact, I've just sent a article saying that it is effective using Indian tools as well as foreign tools. And we need, of course, even if you do everything should be done below 6 years. After 6 years, the results will be extremely poor. Child cannot be. Your idea of doing a therapy is to prepare the child to go to LKG, UKG, or class 1. That's the point. Now, DSM-5 revision has a lot of changes, but still the DSM-4 has a lot of meaning. It had what is called, they never said ASD, they said autism, the high functioning Asperger syndrome, PDD not otherwise specified, then child disintegrative disorder. All these are not being used in DSM-5, yet it has some importance. As I said earlier, it may be social communication deficit, restricted repetitive patterns of behavior, and sensory problem. Now, sensory problem is extremely important if you want to see the child improve. So we need to understand that. Social communication, as per DSM-5 criteria, persistent deficit in social communication and social interaction across different contexts, not accounted for by general development delay and manifested by any of the following. That means if the child has global development delay, it is not autism, it is global development delay. Deficit in social emotional reciprocity. That means when you just play with the child, as you come, good morning, how are you? You start playing with the child. The way they respond immediately, it's a normal child or autistic child. That is one. Deficit in non-verbal communicative behavior. Even if he can't speak, they should be able to do non-verbal communication. You do all the do like this, they will repeat it. You look at it. So many things. This may be just by being taught, but I'm saying they respond to you in a way, smile at you. Their face show that difference. Deficit in developing and maintaining relationship appropriate to the developmental level. Okay. Then DSM restricted repetitive behavior, stereotype or repetitive speech, motor movements or use of objects. Same thing, repeat the same movement. Excessive adherence routine. Not only they will have adherence, they will expect the mother also to have adherence. You put a plate there, it should be put in the same place. Highly restricted fixated interests that are abnormal in intensity or focus. Some particular issue, they may have too much of interest in that at the expense of others. Then restricted repetitive behavior continued, hyper and hypo reactivity to sensory input. All, if you do a short sensory profile, you will find either they are sensory seeking or they are hyper. They put sound they can't tolerate. They put the hand like this. Okay. The certain texture of the shirt they can't tolerate. They can't tolerate certain, even the floor. The texture may be different. Symptom must be present in early childhood. Symptoms together must limit and impair everyday functioning. What else can look like ASD? It may be attention deficit hyperactive because that is also part of OSD. So you need to separate out whether it is ADHD per se or autism. And the best way to do that is now England has come out with, we had 10 years, we had spent, designing the tools for 10 neurodevelopment disabilities. And one of the tool is NDSC, neurodevelopmental screening tool, which can identify all the 10 disability. NDSC, neurodevelopmental screening tool by England. Non-verbal learning disability, obsessive compulsive disorder, they may have that. Anxiety plus language delay with or without sensory, cognitive delay plus anxiety. So that means many of these so-called comorbidities may be part of autism or may be separate by itself. Then by disability, just look at the last one. In 2000, if autism was 1 in 150, now it is 1 in 88. Look at it, 2008. So this is a data from CDC Atlanta, clearly showing that things are changing. Things are changing. Same thing here, 75, 1 in 5,000. Now is 1 in 100. 2010 is 1 in 1,000. 110, sorry. So 1 in 5,000. So it is really autism's peak data this go. It is increasing tremendously. That's why I said there is enough data to show that it is increasing. Now, we have a book on autism spectrum disorder, which I am re-editing for the second edition. Now, what does this show? In our own South Korea, prevalence was 1 in 38, forget about it. 16% with intellectual disability, 12% with superior intelligence, and 2 to 2/3 of them were mild form. This is a Korean experience. What do they say? They 16% also had intellectual disability. On one side, you may have intellectual disability, other side, they may have hyper intelligent children. Now, what do you do? How do you diagnose all this? We need to have a developmental evaluation clinic. So what our own CDC developmental evaluation clinic shows that 16% were normal, although they were referred as developmental, had no problem. 49.9, that means 50% children with problem has only developmental delay. Speech and language, 14%. Autism spectrum, 0.8%, less than 1%. This is the data across the world, less than 1%. Okay. Now, etiology, there are a lot of publications on the neurobiological part, gene environment, role of immune, gastrointestinal. But for practicing pediatrician, none of these are so important. But what is more important is what I just told you. Risk factors, most important is not playing with same age children. I think today you go back only with one message, that if you don't have a child to play with, the chance of getting autism is 20 times more, not 20%, 20 times. So wherever Anganwadi is there, whether it is good or bad, clean or not, whatever it is, encourage the child to be put in Anganwadi, not in those sophisticated preschool. What is the difference between big school? You pay in thousands and lakhs, and what do? They make the baby child put tie and shoe and all that, but don't let the child open up. Whereas in an Anganwadi, as soon as they come, they'll say, teacher, teacher, I saw this, I saw that. All are excited about it. You know, that is what the children needed. That's the most important. Okay. I said it, not telling stories, songs to the child 3 times. No breastfeeding in the first 6 months, 3 times more. Genetics is very complex. So I'm not going to talk all this. Only thing that you need to remember is, if it is a autism female child, you should think of Rett syndrome. Okay. And a male also may have a problem. And the MECP3 is an abnormality that you are going to find. So a genetic test is not required for every child. Okay. But if it is a Rett syndrome suspected in a female, then you may need to do it. Now, there are some studies which says that if the mother is on SSRI, there is a twofold increase. Forget it. That's not such a big thing. Now, what is in autism clinic, what is the profile? Less than 2 years, 12%, 2 to 4, 62%. So your focus should be on 2 to 4. After that is left, 4 to 6, 23%. So 2 to 4 is the most important that we should be focusing on. Now, what are the simple way for a general pediatrician? For a general pediatrician, what we should remember is almost 100% of them will have poor eye contact. They won't look into your eyes. Somehow, whatever you do, they are not going to look into your eyes. That is the biggest point. Okay, they have poor communication, verbal and non-verbal. They will not point out to something. They won't, mama, look at this, look at that. No. They may actually tell, I want this, I want that, but they won't enjoy something with the mother. We call it proto-declaratory and etc., etc. No emotional reciprocity. That means if the mother is crying, baby doesn't feel anything. That emotions they are not able to understand. They may have hyperactive behavior. They may not have pretend play, stereotype behaviors. Most important, echolalia. What is your name? They will call back and say, what is your name? That is important. Now, is it effective or not? Therapy, is it effective? Look at a sample where of 659 cases. Let's look at the CARD score. We found in our clinic 659 cases, non-autistic 26%. They were referred as autistic, but we found they are not autistic. Mild to moderate 50%, severe 32%. Get an idea that half of them will be mild to moderate, another 25 to 30% will be moderate to severe. Now, one of the problems that most doctors face is you do not know how to tell them that there is a problem. If you say your child has autism, you can expect the mother to go through certain stages. And the first stage is lack of acceptance. What does it mean? They deny. Denial, we call it. No, my child doesn't have. Doctor has gone wrong. I'll go to somebody else. Okay, they waste some time. Then they are angry with you, angry with the therapist, angry with God, angry with everybody in the world. Okay? Then they start bargaining. Start with denial, then they start bargaining to God. He said, I will do this, I will do that, let my child be okay. And then go into depression. And finally, they will take acceptance. Usually it takes about 6 months for every child to go through. So what I do is, I tell my mothers that normally it takes 6 months to go through all these stages. Can we do it in 6 days? You came today, Wednesday, or Thursday today. Come back when you come on next Thursday. 6 days you can cry, no problem. Crying is absolutely okay because any mother will cry. You may deny, you may get angry with me, you may get angry with God, okay? You may go into depression little bit, but ultimately better accept and come back. Next week when you come after 6 days, you should have accepted the diagnosis. Okay. How do I say the diagnosis? We have actually the simplest thing on earth is TABC. Indian tool, validated against CAS twice and published. Okay. What is CAS? Childhood Autism Ratings. This has 20 questions in 4 domains. So the maximum score will be 80, minimum 20. Very simple. And what do? Social interaction, there are 5 items. Communication, there are 4 items. Behavior characteristic, 5 items. And the last, sensory integration, has 6 items. And this sensory integration, if you look at carefully, you may not even do short sensory profile to identify the sensory problem. This will help you to identify the sensory problem. Now, what do we do? How do I tell the mother? There are 20 questions. You have to sit along with the mother and very patiently ask the mother only 20 questions. Does your child have this, this, this? Don't push anything on them. They'll say, yes, it's 1, 2, 3. No, so it is too much or little, they will do that. And
So,
then what do we do?
sir,
I say,
sorry.
yeah, got it?
Sir, sorry to interrupt. Actually, your slides are coming small and your picture is coming big. So, delegates are not able to see the slide properly.
Everything is okay here, so I don't know what to do. Here it is perfect screen. I am only in a spot in the above.
But,
Just like-
sir, on the laptop, it is like I request all the delegates to open it on a laptop, not on a mobile.
Mobile,
Then
you
it
won't
would
get
be
it.
okay. Yeah.
Mobile, you won't get it. I
Yes,
know.
Okay,
yes,
sir,
madam.
you can continue, sir.
Yes, it is coming on my laptops, madam.
Laptop, it will come properly. Mobile, mobile is only for doing meeting. It cannot be done for, scientific presentations.
Okay, sir, you may continue, sir.
Okay.
Thank you, sir.
So what I do is, when my development therapist is a girl who might be trained to become assistant to you. When they have administered the scale, then I ask the mother, did she ask you all the 20 questions? Yes. Do you agree with the way she has ticked it, or she has given him 1 or 2 extra? No, sir, it is true. Then I ask them, is there a problem? What do you think now? After going through this 20 question, is there a problem? Sir, look like there is a problem. Okay. Now, what do you think the problem could be? Did somebody say some word? If she's not coming out with the word, I will say, did any doctor before mention something about autism or something? Yes, sir. Some doctor has told me something about it. What do you think? Your child has that or not? She will say, look like it has. Get the point? So slowly break it. Don't say it is there. Okay, that is the most important, breaking the news. In the clinic, if you have a child, you want to rule out all other possibilities. Don't be adamant on the diagnosis. Even if TABC is positive, even if C is positive, child is American tool, childhood autism rating scale, then also we must make sure that child doesn't have any other problem. So what we normally do is quickly do the Trivandrum screening chart. You will tell you about development. Quickly do the language evaluation scale less. So you will get an idea about the language. It is receptive or expressive language problem. Actually, there's a new tool coming called SES, communication evaluation scale, that will even be better. And then you have Denver development. If you have the tool, you can use it. That will tell you the problem. Hearing assessment should be done by OAE or BARA, whatever is available with you. And then you add Trivandrum development screening chart. Okay. And detailed evaluation can be done. Vineland social VSMS, Vineland social maturity scale, reels. If you have a assistant, trained assistant, you can do receptive, expressive, emergent. At least in medical colleges, you must do. I am not looking for a pediatrician doing an evening clinic to do all this. No, it is simply not possible. But in a medical college where you have lot of postgraduate, they must do it. It's a sin on the part of the HOD if you don't make facilities for these things. Government or private, this is absolutely. I will say that you won't go into a operation theater without an artery forceps, will you? It's something like that. You cannot do developmental without having these simple tools, not a complicated. And then, of course, childhood autism rating scale cards. This much minimum you should have in a teaching institution. Of course, you can, if and the person who do this is called developmental therapist. Development therapist is a person who is trained 2 years for this, and they are taught 3 things. They are assistant to the perinatologist or obstetrician. They are assistant to the neonatologist. They are assistant to the pediatrician or developmental pediatrician. So 2-year training, which I have been doing for last 25 years. The whole of Kerala, we have plenty of them. Now I am trying to make it a national way. So what we do is, anybody want to send somebody for training, send. Just now we finish M.C. child development girls. 6 of them finish almost 1 year training. They already have M.C. They have 1 year training with me. Naturally, they will be very good at doing this thing. You identify a person, send to me for training. I will make sure that they are as good as me or even better than me. That's the whole point. Okay. Now, tantrum development screening, I don't have to say, you all are familiar with it. Then this is a screening and evaluation by speech therapist. It could be, everything need not, we also must get, if you have a speech therapist, make use of that. Just because they are not there, don't say I won't do anything. You will still do early language intervention. But if you have somebody, it's all the more best. Now, what do we see? This is a language evaluation scale to tantrum. Okay, suppose the child is 24 months, just put a scale like this, 24 months. What do? We put a scale like this, 24. Like this, 24. That means up to 22 items he should have done. See, 24 means the item not crossing is up to number 21. 23, 24 onwards, it is crossing. So we need not do it. The item stopping on the age, left of the age line, you need to do. Crossing one, you did not do. And look at validation of TDSC and less, 0 to 6. Look at it. TDS, forget about TDSC, take less, both. 99% negative predictive value. That means, why am I talking so much about TDSC and less is because TDSC has been validated against DDSC, less have been validated against the more complicated test called REELS. Now, the negative predictive value is 99%. That means if you do with both, 99 children out of 100, you will have the same result. One child, there may be slight difference. So that is important. You don't have to do any complicated tests. And look at this, the validation of TABC against the CARS, CARS. What does it happen? Less than 35, no autism, 36 to 43, mild to moderate, more than 44, severe. Negative predictive value is 99% again. Now, I have published it again now, another study showing almost the same, 98.5%. Now, look at chat and CARS, DABC against chat and CARS. Chat is the one we used before less than 2 years. And look at the negative predictive value, 93% for chat, 99% for CARS. Look at it. So, Trivandrum Autism Behavior Checklist, although it's a simple checklist, it has shown very good psychometric properties. Now, TABC against CARS 2, we have redone it now. The CARS 2 new tool has come with slight modification. There also negative predictive value is 98% or 97%. That means it is as good as CARS. Now, what do we do with early intervention? We have different early intervention package. Now, this is from 2008. We have started them, then 10, 12, and we have every subsequent batch we have been improving. Revised in 2013. Now it is revised in 2024. What is happening? See, effectiveness of early intervention. Please look at it carefully. Now, what happened? Severe was 27 pre-intervention. After 6 months intervention, it has become 13. That means less than half. Whereas moderate remains the same. Mild was only, non-autistic was 4 cases. But at the end of the intervention, 19 became non-autistic. That means how many? 16 have improved. Okay, or 15 children have become non-autistic, clearly saying that it is effective. Now, something else we need to do, what is called individual care plan. After evaluating the history of a child, a detailed plan is prepared covering all the aspects of physical, emotional, and mental growth. We call it biopsychosocial model. You sit with the mother and look at what all can be done at home. That is called individual care plan. Like we do IEP for learning disability, individual education plan for IEP. And biopsychosocial model, as doctors, we were all trained to look at biology. Any textbook, you will have history, prevalence, causation, management. That management is medical management, but that time is over now. The management includes biological management as well as psychological management and social management. An autistic child, you know very well that there is no drug that is going to cure it. You may, for some problem, for all the problem related to autism, we may do risperidone. That is the only approved drug for treating the side effects of or whatever the comorbidities of autism. Risperidone in small dose, whether it's hyperactivity, behavior problem, whatever it is, even sensory problem. Okay, the typical drug we use for hyperactivity and all may not help in autism. There's enough publication saying that risperidone is the only drug that should be actually used. Now, so that means our biological management is so limited. We need to have psychological factors. We do a SWOT analysis, SWOT. What is what? Strength, weakness, opportunities, and threat of the family. For example, what is the strength? Both the parents are IT. Great strength because there's scarcity of money. But what is the weakness? Parents have no time to sit with the child. Okay. What is the opportunity? You may be able to employ a trained therapist for the child alone because money is not a problem for you. You get the point. So that becomes an opportunity. And what is the threat? Whatever you do, another person cannot replace the mother. There's nothing in this world that can replace the mother. So that is a threat. The grandmother having a mother-in-law may be an opportunity, may be a problem, or maybe a support. Some mother-in-laws can be so supportive. Some may be pulling your leg all the time. It is because you ate something in the pregnancy. That's why child got it. So whatever you have strength can become a threat also. That's the point. Social factors, socioeconomic factors, the marital status. Now that is something very, very important. Most of these children, the parents get into trouble because so much of stress for the parents, their marital relations get affected and they simply become negative. So I have a scale called Partner Assessment Scale Tantrum, and we applied that to all the mothers quickly. 7 questions only to say whether they are okay or not. For example, we ask them in reality how much you're happy in marriage, in fantasy how much you're happy, your support system how much is there, 50% more or 50 less than 50%. Like that, each item you look at and find out where is the problem in the marital relation. Okay, and that helps you to give a. Remember, what is the difference between a pediatrician and a developmental pediatrician? Pediatrician is the one who will make the diagnosis right, correct the drug in the correct dose, send them off. Okay, whereas a developmental pediatrician will spend 1 hour with the parents, with the child, play with the child, try to understand the child, and don't see 100 cases. You may see only 10 cases. But at 10 cases, you will spend at least 40 minutes for each child. And what is the difference between a pediatric neurologist and a developmental pediatrician? Pediatric neurologist is the one who is adamant in getting a diagnosis. The last bit of the diagnosis they will make. But after that, they don't know what to do. Only the drug they can write. But developmental pediatrician can be with the family, can be supportive to the parents, can interfere in every activity of the parent so that everything is planned towards the welfare of the child. Okay. Now what is this biopsychosocial model? I'm just giving an example. Suppose I'm just giving a typical example of a child. It has Down syndrome who has associated problems of ASD, pulmonary failure to thrive, whatnot. Then you are psychological. The child actually also have global development delay, communication delay, some adaptive problem, LD, ID, whatnot. Then social aspects, over-dependent parents or caregivers. They are not trained to do, even toilet training is not there. So potential for poor scholastic thing, social acceptance and all that. So you divide into 3 things. There are so many biological problems, then there are psychological problems, and then there are social problems. Okay. Now, what is the therapy we do? We do developmental therapy. Developmental therapy is not only for a high-risk newborn, it is also for the autism children, particularly less than 3 years. What do we do? This is actually our own development therapy unit. What are the things we do? What are the steps we do? The first one is the prayer. Now, the focus here isn't on the religious context, but to promote attention and school readiness. When he go to a LKG, UKG, child will be expected to do this prayer, whatever prayer the school has. So you teach them to do that. Will they do in the first day? No. For 3 months, they may not do it. But after 3 months, they will also stand quiet and doing like this. So it is a way of training them. And the second will be large group instructions. The aim is to make child follow commands not directly or directed to them. It encourages observation learning, physical exercises, merry-go-round, skipping the thing, 1, 2, 3. There are sheets in which 1, 2, 3, 4, up to 10 is written. They'll be jumping from first to second to third to fourth. And when they end up 10th, they'll go and put the ring in a place. So this becomes a routine. Instead of sitting idle, they start relating and every other child clap. So when a child is doing, when the other children clap, they are actually learning socialization. Okay. Individualized small group instruction. It helps in developing attention, eye-hand coordination, teaching about animals, fruits, teaching letters, writing skills, speech and language development. 2 or 3 mothers sit together, only 2 or 3 mothers, and each will be helping each other, trying to teach. Instead of you doing it, if you keep on doing it, mother will not learn how to do it at home. Whatever we are doing here, the mother is expected to go back and do. So every house, if possible, one small room, otherwise a corner of the room where the mother will be able to repeat whatever we have taught here. Then you have structured games, like classical game, even block building, toy building, all sort of things, the noise making thing, where to press it, where to do it. Only 3 mothers, if you notice, here, actually, even individually, the mother is sitting with the thing. The therapist will stand behind and don't interfere, but keep on advising, counseling them how to do that. Help them in doing that. Snack break, very important for socialization. Every parent brings some snacks and they actually share to each other. Children learn to share, take from somebody else's, give to the other child, that socialization is taught in this snack break. Then you have coordinated activities for eye-hand coordination, clay modeling, painting with fingers, cutting out shapes. Okay, so the therapist help them to do that, but it's the mother who make them do it so that the mother know what to do at home. Normally, what happens in OP is we give them so many instructions, they don't understand half of it. By the time they're home, they have forgotten most of it. Now, unstructured free play. There you are making bubbles, blowing bubbles, each one jumping around to catch the bubble. So what happened is a very free play, unstructured free play. Bubble play, we call it. Then we sit together and do what is called planning for home intervention. I will, for this, most of the time, I myself will sit. Then you have the developmental pediatricians trainees. We have 2 persons across the country, and you only have to apply. Actually, I think the time is now to apply to the Indian College of Pediatrics for fellowship in developmental pediatrics. We have 5 or 6 centers active. There are 12 or 13 centers, but 5 or 6 are very active. So you just say what is your choice and apply. I don't do any selection. Selection is done by headquarters, and 2 MD pediatricians will be sent to me for 1 year. So the next one is starting, already they have called. Now that is the one sitting there. The person sitting there is 2 of them. My first batch, 2 of them are there. Then developmental therapists are there. And together we do. The point is, we don't decide anything independently. We decide together what is best for the child. Okay. And then effectiveness of CDRC model therapy on core symptoms of autism. This is actually 82 cases. I'm publishing 153 now, where, what has happened, pre-scored, same thing I showed before. Out of total 82, severely autistic, 39 has become 18. Moderate 43 remains same, because mild has, the non-autistic has increased. There was none, it was 21. That means 21 cases have become non-autistic with therapy. All these are effectiveness of therapy showing. This is, if you go little more detail, look at total TABC score. 44 has become 39, very significant reduction of significant reduction of 5 points. Social domain, again, 12 has become 11. Communication 10 has become 9. This is the average score. Behavior domain 10. All are p-value positive. That means it is effective. At every domain, it is effective. Then there is a role of probiotics. I'm not saying that probiotics is the answer, but we have done a study published showing that probiotics can reduce gastrointestinal symptoms a lot. I won't read all this, because what I would like to say is, I think Shefali Gulati in All India Institute has published, I have published, there was some other publication generally saying that probiotics can reduce gastrointestinal symptoms. Then role of music therapy. Individually, music therapy alone is not going to do any good for the child. With all other things, if the particular child is interested in music, then his socialization will improve so much by music therapy. Now, sensory integration extremely important. As a pediatrician, we are never told that sensory problems are important. Only when you start working with autism, you realize they have lot of sensory problem. It is either hyper or hypo. Either they like to be hugged or they don't like to be touched. Both sides, hyper or hypo. Voice also, they may be intolerant to voice, or they may like to hear loud music. The extremely opposite. Smell, another one. Even the slightest smell, they cannot tolerate. Some children love even bad smell. Even sticky stuff. They don't like to eat with the sticky stuff. They only do with spoon, but some of them like to mess up the whole thing. So two opposite. So what is happening is, just now we are completing a study on sensory integration. Another 3-4 months, we will be able to give you the data on that. Now, I talked about SWOT analysis. The strength, one particular child, I am saying the strength, how to write it in the chart. Strength is no serious marital problems. Okay, we have done partner assessment scale and showed there is no serious marital problem. That itself is a huge strength. Like a bullock cart, if both the ox is going this way or that way, you cannot, two horses, both are going the left and right, then you can't drive. But if both are going in the same direction, that is what a mother and father should be. Weakness, both parents are working. So what happens? I said it earlier. They don't have time to spend with the child. Opportunity, availability of grandparents, provided they are not itchy, they are not troublesome. The grandparents can be wonderful. And challenges, entry to preschool or class 1. Our objective is, I must be able to make this child go to class 1. And where do I do the training? You can do it in Anganwadi. Most places, if the mother also go and help them, they don't mind taking these children to Anganwadis. Medication summary, I will say in one thing, review of 19 articles, it is showed that risperidone 0.25 to 2 milligram per day, not kilogram, per day, minimum. Initially, you should only use risperidone drops so that overdose will not be there. And we have had cases where instead of saying 5 drop, they are given 5 filler, complete filler. Don't do that. Whether it is hyperactivity, impulsiveness, it is atypical antipsychotic SSRI. Rigidity, ritual, again same thing. Aggression, self-injury, it is again same. Anxiety and affective symptom, again atypical antipsychotic. So that means atypical antipsychotic, SSRI or risperidone is the drug of choice. Okay, now national scaling up. When you want to do across the country, how we do it, you must learn two tools. We spent 8 to 10 years developing this. There's a tool called neurodevelopmental screening tool with almost 99% sensitivity and specificity, which actually is related. There are 13 items in that. So when you have a bigger child, younger child, you can do with the TABC. After 6, TABC cannot be used. So you can use, it is called neurodevelopmental screening tool of England. And what can do, it will tell you child is hyperactive, autism, etc., depending on the item that is positive. So AS3 related 13 items, that means you can definitely pick up. The second one, England appropriateness criteria for ASD. It is called England ASD tool. This is a summary tool which will tell you whether it is good for ASD or not. This is what we use. Okay, where it has been supported by NIH USA, Autism Speak, National Trust in India, and RBSK. And I must thank my two real good colleagues, Dr. N.K. Arora and Shefali Gulati, and many others who helped me do this project. Although I was principal investigator, most of the work have been done by, the coordination was done by Arora, and the academic part was done by Shefali. Now, this is for you. Till now, it was for, when you talk about autism, we always talk about refrigerator mother. We used to talk about, there was a book also on that, refrigerated mother. Mother is cold and clammy, do not respond. That is why the child is not responding. But I said, no, it is not. It is actually mother becomes like that because the child is not responding. Most of us teachers know that when you are teaching, there'll be at least 1 or 2 children who look in your face very admiringly and smile and all that. Then it's an encouragement for you to talk. If everybody is looking, sit like that, you don't feel like talking. In fact, that is a problem with the webinar. You don't get a feedback from the participants. Okay. So the items I said is 50% below, above 50. Reality means with all the good and bad in marriage, overall, are you happy? In fact, you people can do it now. Don't write it. Just write reality. You in your paper or mind, you read whether above 50 or below 50. Second one is fantasy. All of us have fantasy till the death. And does it satisfy your fantasy? That may be partner, it may be child, it may be profession. Don't think that you only partner has to be a fantasy. Your profession may be your fantasy. Your child may be your fantasy, or partner can be one of them, any one of them. Financial support from family, in-laws, family, peers, your friends will support. Is it above 50 or below 50? Attitude, you think of marriage as a serious business or not for changing every third year. No, you think if you are stable about it, most of the problem you'll write off, to forget it. This is all part of the game. Then sexuality. Are you sexually happy with the sexual partner? I'm not talking about the score. Score may be very low, but you could be still happy. What is that? A caring person without doing anything also can make you feel happy. Not saying I love you 20 times a day. You can't trust them. But somebody who care for you, when you need him, he will be available for you. Once the wife is sure that he is available, then she won't complain about anything else. Giving type personality. Most of the men are taking type personality. They want only take for themselves. But if they start giving to the wife, if it is school children, I will say somebody who will make you happiness. Your partner who will make you happy. If a college students, I will say somebody who give you pleasure. If it is husband and wife, you will say orgasm. I think we should use that words. Last, of course, here I have written conflict resolving. Now I have changed it into one problem is conflicts are never amicably solved. So I said sharing the same values. What do you mean by sharing same values? If one is crying seeing a movie, the other one also should be crying little bit. That means you both have the same value system. Most important. I will only read the guidelines because we are taking 1 hour. Start intervention as early as possible, before 2 years, but definitely before 6 years. Make intervention fun and low stress, and give incentives like food, toys, smile, hug, do all that. Don't talk about giving stamp and all that. That doesn't work with autism children. Normal children it will work. Token, all that what we learned in behavior therapy will not work here. Find and use sensory pathways, whether they are visual learners, auditory learners. So if you are a visual learner, give a lot of visual stimuli. Build, strengthen, create, organize neuro pathways by auditory, sensory, and visual integration. Keep the child engaged and stimulate. High quality computer softwares are available for this now. Help child meet sensory needs meaningfully. For one example, a child is having excessive hand flapping. Doing push-up may be useful. Include regular physical activity like aerobic, walking, running, swimming, etc. If a papa or mama is going with the child into the open playground, they will do it. Don't be afraid about what others will think about your child. Be proud that I have an autism child and I am looking after. Even if you are Prime Minister of India, you should be proud about your child. Then only the country comes. First, your child should come. So that is the most important lesson we did. We should not be, feeling bad about my child has this problem. So what? Never let the child and mother fail. Praise for achieving goals. Support the mother. Every small improvement, the mother, for them, it's like a PhD, achieving a PhD. Child was not using one word. Now he has started using one word. The doctors should be. That's why I said developmental pediatrics, you should not try to do it along with your busy OP. Keep a separate day for this, where you are completely free, relaxed, and not in a mood to take emergencies. Structured, uninterrupted instruction essential. Clear instruction, multiple cues, child's choice, stimulus, reinforce, rewards, etc. Continue to do the same thing by family members. That means you tell them, prepare them in the clinic, send them to do. Don't bombard them with too many instructions, 2 or 3 every week. So that when they become comfortable with that 2 or 3 things, next time give another 2 or 3. Okay. I won't read this package because it takes a lot of time. No, it's not required. Okay. So in summary, 3 things I will say. There are a lot of therapists now doing therapy. Now, actually, it has opened up a huge area for every therapist. But what is happening is the poor mother is running between therapists. In the end, they are not getting enough. Instead of that, we should train development therapists. Let it be a nurse, even a diploma nurse. Somebody should get 1 year training, and they should be your assistant to pediatrician. We can do most. Of course, once the child is bigger, you have to send to all type of therapists. But running between therapists is the biggest, mistake the parents are doing. They have no choice. Anything you go to Bombay, you have this surgery, I don't want to say call the names. All that costs 50 lakhs. Parents are willing to spend. Will it do any good? It won't do any good. None of this magical cure. So I tell parents, if the person is saying spend up to 1,000 rupees, I will see better for your child, then it's okay. Most people can have. Suppose you say 50,000, then think twice. If you say 1 lakh, don't go for it, because there is no therapy in this world which has shown improvement. I'm challenging everybody. If you show me a therapy that has shown effectiveness, I will bow my head. So most of these people are just, what happens, for example, instead of communication, most of the time they are focusing on speech. In the end, the child will not have speech, child will not have socialization. What we do is better than that is if you have a Anganwadi, where socialization occurs, communication occurs, you have the speech occurs, child learn to be with everybody. So my message would be, don't go for high fluent things, don't go for international tools. All international tools we have done our own tools, and that has been validated, published. So why not we do that? And always be a better person. Every time you see a child with autism, thank God that at least you didn't give me this problem. That you should be careful. Thank you so much. Except 5 o'clock. 1 hour.
Thank you, sir, for the excellent talk. Thank you, sir. Sir, we have few questions in the question answer panel.
Yeah, please read it. I'll give the answer. Please read it. I didn't say a few things purposefully. For example, there are a lot of new therapies which was very popular, but now most of them review saying that they're not as much as that. That's why I didn't want to say that. I don't like to say negative. That's why I'm avoiding those things. But if you ask the question, I'll tell you the answer. Okay, please.
So one question is from Ashok Mehta.
Yeah.
Once chat is positive, how do we confirm diagnosis?
Confirmed diagnosis in less than 6 years, CARS is more than enough. Childhood autism rating scale. Above that, there are many things like ADOS, ADIC, whatnot. And Government of India has something called ISA, ISSA. Okay, ISA is excellent for above 6-year-old children, but below 6, it's not good. Okay, I'm saying because I was one of the experts who was called to look at the NIMS tool. NIMS spent a lot of time and effort and money to making the tool. So I objected that below small age, there are very few items. So it is not a good tool. But then they said, we need something national. It has to come from a national center. I said, okay, great. So Government of India now talk about ISA tool, but I don't use it for less than 6 years because it's not so sensitive. But above 6 years, it's a wonderful tool. That's the point. Okay. Confirmation. But if you have to certify, you have to do ISA because government accept only that. Okay.
So second question is lowest age when autism can be labeled.
What is the age?
Lowest age, sir. What is the lowest age when we can label a child as autism?
Every year they say International Congress in US on autism. I happen to attend one of them, in which what I found is if you have an elder child with autism, then they may start doing even by 1 year. Even below 1 year, they may start looking for some evidence. But for practical purposes, you keep videos of our children less than 1 year. Later on, when we suspect autism and put these videos back, hey, he had something there also. You cannot diagnose, but you can suspect. 1.5 years is the earliest where you can diagnose. Most of the children will not be diagnosed before 2 years. But after 2 years, it becomes a little late. But up to 3 is not very late. You can get excellent result. What I say is, you get me a child below 3 years, I'll give you 100% result. If it is 4 years, between 3 and 4, it becomes 75%. If it is 5 to 6, it becomes 50%. After 6, no guarantee. I cannot guarantee anything. This is a rough estimate that I say out of so many years of experience. Okay. Okay, sir.
The next one is, sir, how do we follow up a children with ASD? Do we use the scales used for initial assessment?
No, what we do is, of course, we will make sure there is no vision and hearing problem. That is compulsory for any neurodevelopment disability. After that, the scientific study says that you should do every week. What we do is minimum one, individual session, one group session, minimum. If possible, 2, but at least 1 each. And then you do for 8 weeks. After 2 months, do reassessment with TABC. And you can see the score coming down. If you want to do CARS, again, you can do, it will show score come down. At least before 6 months, you cannot get a statistically significant difference. But 6 months, you will get it. That's what I'm going to publish. Already it will be gone to the journal. Okay. And what it shows is that, TABC, all domain, there is a statistically significant, score reduction. Cars, individual 15 item, there is a reduction. The in between that data I have shown, but this is a final data. Okay. So 2 months, the doctor should see again 2 months. Otherwise, your therapist can do. When I say therapist, you will ask me, we don't have, again and again, I'm saying, we don't have development therapists. What do I do? You send anybody. It could be M.S.C. child development. It could be a graduate nurse. If you can't get a graduate diploma nurse, could be anybody who understands little biological, medicine issues, biological. That person can be trained in 1 year. Now, what the program I am doing is I give 1 year training. Actually, yesterday only 6 of them left after 1 year training. They already got job. So 1 year training, and they will be very good in doing all this. We have another program called ASAP program, +2 girls. 6 of them are going to graduate another one month. Exam is get over now. ASAP, that's +2 girls again, but they are there for 1 year or one and few months training also. 1 year training is the minimum, and they can do very well. But if you already have a graduate nurse or something, 1 month training is enough. Just to manage issues, 1 month is okay. If you're a pediatrician, 1 month is enough. If you're an MBBS doctor, 1 month is enough. You get an idea of the whole thing. Okay.
Sir.
Yeah.
So one
Some of
question
the
is, where
children
do
are
we get all the scales? So one person has asked, where do we get all the scales that you have
You
mentioned?
send me requests. We will have a periodic training for all the scales together. That will take how many days? Ideally 1 week, but 1 week for a pediatrician to come and may be difficult. Minimum 3 days. In
Okay,
3
sir.
days, we will give you the kit. We will do the training. Minimum 3 days, ideally 1 week.
Okay, sir.
Okay.
Sir, and Acceptor 10, what is its role in hyperactivity? One question in the chat box.
Hyperactivity is a separate topic where all these drugs are very effective. But the consensus is that those drugs are really not effective in autism hyperactivity. The mechanism is different. So some people use it, nothing wrong. I know neurologists using it. But the consensus is that risperidone is the best to take care of any sort of problems. Okay.
Sir, congratulations for the excellent presentation, sir. And sir, my question was also related to hyperactivity, sir. Most of the children, many children nowadays are being brought to us in our clinic, hyperactive children. But how to pursue the parents, sir? They are not ready to agree to this, that the child is hyperactive.
Yeah, no parent will agree, sir. See, you must understand that the topmost neurologist of India had his I won't say the name, had his grandchild had this one, Down syndrome. He refused to accept. He is that godfather of neurology, the neurosurgeon in India. But he refused to. It happens. We had our most respected teacher of medicine. All his life, he taught that, gastritis and all this complaint may be part of heart attack. Don't give Gelusil and send them. But when he had himself, he refused to accept it. The PGs were adamant. They pushed him and took for ECG, showed the ECG. He didn't believe. He could not believe his ECG. And by the time they could push him into the van, he has collapsed and died. So this happens, sir. Knowledge is not different from other things. There are some, I have seen one politician, without naming, I will say, he may do anything in this world. But if the doctor say, don't go, he will say, no. I will not move because my doctor has said you need take rest. You understand my point? That is a habit. He says, my doctor says something, I will obey. Nobody else in this world I will obey. So most parents are like that. They have it. But again, ADHD, we have actually separate group therapy session for ADHD. All this we have separate group therapy. Not giving medication is only one small step. It is, I will tell you, it is as good as if you have 200 OP in a medical college, private even won't have, medical college casualty. You have so many patients rushing on you. What do you do? Everybody without looking, you do urine, albumin, sugar deposit, TC, DC, BC. You give the slip. Fellow is happy, he go around the whole day, and by the time you come with the result, you are already OP is over. Get the point? Haven't we played this trick? Is writing medicine is only a way of getting rid of the parent. You are not actually addressing the issue.
Wonderful.
Thank you, sir.
So what is
So
the role of
one question was regarding role of omega-3 fatty acids.
Everything is good. It's good for you, good for me, good for the brain. But don't say it is good for autism,
Autism.
because nobody has proved it. All this nonsense. That's why I said probiotic also. I said Shefali has published a paper. I have published a paper. I have seen few other papers, but I didn't say it is foolproof or something. Some suggestion is there. You want to use it, doesn't matter. But if you didn't use it, it's not a mistake. Omega-3 anyway is good for brain, so nothing wrong.
Dr. Inder, any more questions we have?
what should be the role of a pediatrician in civil hospital in treatment of autism spectrum disorder after making a diagnosis? Was asked by somebody.
See, actually it is difficult. Unless you have a day for that, or for the development disorder, a busy pediatrician can do nothing. That is the answer. We only can do this one. I remember when I was in Punjab, Ludhiana, CMC. Punjab, now I know after 50 years what has happened. By the way, next year I am completing 50 years as a medical teacher, as a pediatric teacher, 50 years next year. So what we used to do is, I don't know whether the habit is there. Some patients like to eat medicine with dahi. Some like to do with ghee. Some will like to do with that. So what happened? 5 of us sitting together, 5 will say different things, confusion. So we say today is Monday, every medicine is with dahi. And everybody is saying, he will go and ask the next fellow. He said, oh sir, you should eat only with dahi. Patient is happy. Sometimes we do these things to make patients happy, which with no scientific evidence whatsoever. But then sometimes you have to do, because after all, trust of the parent. I am telling you, your question is excellent. You cannot do something unless somebody is supporting you. NGO, somebody is supporting you to have a room and have a therapist, have a something. Then you can do. One person cannot do, because I know what is a busy in a civil hospital, general hospital. It's impossible to do anything. Even if you suspect it, that is excellent. That's all. And you can do TABC at least. Okay.
So in our hospital, we have a therapist, so I send them patients to them. So we have.
If they are trained, therapist doesn't mean anything.
Yeah,
therapist may be
I have a therapist in a civil hospital Sangrur.
No. Most of these therapists have learned for adults. They are not seen even children, many of them, unless they are doing pediatric post-graduation.
But sir, results are very good.
Very good. Then you ask the person to read this therapy, developmental therapy book. My book is there.
Okay.
Development. If the therapy is good, then they can do wonders. I'm telling you.
Yeah, sir.
Yeah. But they have
My
to be
patients
trained.
have improved a lot.
It is like, when we did MBBS, how good we were doing pediatrics. Whereas now when you look at a child, by looking at it, you know the diagnosis, isn't it? So without that experience, you cannot become good. That's the point.
So one question was asked by Dr. Sandeep, sir. What is the role of expector 10 in hyperactive child?
That has been answered.
Okay,
That has been answered. And I think the only question left is, I think, like risperidone, what is the dose and when to start? I think that was also
I
answered
showed
in
that
the session.
0.25.
Yeah,
It is
was
available at drops. You
okay.
write drop in Hindi, Punjabi, whatever it is, and tell them, make them repeat it. And what do? Actually, I do one more thing. I have 2 MD pediatrician under my training. I insist that both of them should sign it, prescription. The reason is, and you should calculate the dose correctly, because one person can go wrong and even I can go wrong. So better that 2 persons, 2 MD doctors sign it, because risperidone we have had problem. If you do this is my grandchild, no autism.
Sir, actually, we can just go and go on asking questions, getting our queries, with you, because you are an endless, source of endless knowledge as far as autism and development is concerned. And sometimes I feel that
All because of CMC, madam.
How privileged we are to have you as a speaker and been actually listening to you for the last 1 hour. So many doubts have been cleared, and all
All
these
credit to
young.
late Sheila Singh Paul and Manorama Verma. You know,
Thank you.
she made me a fantastic clinician. I never seen a better clinician than Manorama. You know her, no?
Wonderful. So yes, sir. I
Yeah,
know, sir.
yeah.
I know. Sir, then that's the power of teaching. So
Yeah.
hopefully your teachings will take us long way, and we'll be together be able to take care the health care of Indian children in the best possible way. Thank you so much, sir. I just can't thank enough. Thank you, Inder Manjot. You have done wonderfully as a moderator. Sir,
Thank you,
he's a
ma'am.
very bright young postgraduate and now being medical officer, doing a wonderful job in Sangrur. And he's totally inclined to academics, and he's always there for any recent advances, CME. So, Dr. Sandeep is also a faculty in our medical college. He's working as associate professor. And we are really thankful to you for sparing this
Yeah.
precious time of yours
I
for
tell one
enlightening
thing to
us.
all my staff. When I was in SAT, I said, you become expert in something. It may be right toenail. You work on it for 5 years, you get recognized. In 10 years, you will become international authority. But every teacher must focus on one small thing and start working on that. So whenever there is a problem on that, people, that's how you grow.
Yeah,
When I came
wonderful.
with the MD from Ludhiana, what happened? Everybody said join DM, neurology and cardiology in Chitra. I could have got it if I tried. I said, no, I don't want to do it because even if I do, what will happen? Chitra is there, all the big shots are there. Let me take something which nobody wants. That's how it turned into development, and later it became adolescent, later it became young adults. So have your own path, make your own path, keep working on it. People will not recognize you for many, many years, but ultimately everything has to come.
Wonderful, sir. These words of wisdom are going to be the game changer for many of us. Thank you so much, sir.
Thank you.
I just can't, there are no more words that I can say, but we would like to hear from you more often. And we would love you to be in Amritsar. I have
No, I
twice
can't
called
travel.
you
You
for
know
the
that I cannot
conferences.
travel. Medical reason, I
Yeah,
cannot
I know,
travel.
sir.
I
But
cannot
hopefully,
travel.
sir,
But
we
anything
will.
about Punjab, I really enjoy it. You even just, sir, why don't you talk little Punjabi? I love it. You say in Punjabi, I will enjoy it
ਸਰ
more.
ਤੁਸੀਂ ਕਦੇ ਵੀ ਅੰਮ੍ਰਿਤਸਰ ਆਓ, ਪੰਜਾਬ ਆਓ, ਤੁਹਾਡਾ ਸਾਡੇ ਦਿਲੋਂ ਸਵਾਗਤ ਹੈਗਾ ਐਂਡ ਸਾਨੂੰ ਬਹੁਤ ਵਧੀਆ ਲੱਗੇਗਾ ਜਦੋਂ ਤੁਸੀਂ ਪੰਜਾਬ ਆਓਗੇ.
And particularly that beat.
ਅਸੀਂ ਹਮੇਸ਼ਾ
Yeah,
ਤੁਹਾਨੂੰ
yeah.
ਸੁਣਨਾ ਚਾहेंगे, ਹਮੇਸ਼ਾ ਤੁਹਾਨੂੰ ਸੁਣਨਾ
ਬੱਲੇ ਬੱਲੇ,
ਚਾहेंगे।
ਸ਼ਾਵਾ
Ah,
ਸ਼ਾਵਾ.
yeah.
Thank you so
Balle,
much.
balle and all.
Yeah,
Okay.
thank you so much, sir.
Okay,
Thank you
madam.
all the
Thank you.
Good
delegates.
night.
Thank
Good
you,
night.
Kepler, for holding the session together. Thank you so much, everyone. Thank you, Inder
Thank you.
Manju.
And thank you,
Thank
big
Thank you,
thanks
sir.
to Dr.
Thank you all. Good
Manjeet
night.
also
Good
for
night.
making us,
Thank you,
providing
sir.
us this opportunity to join this session.
Good night,
Thank you,
sir. Good
Dr.
night.
Manjeet.
Thank you, sir. Thank you. Thank you so much, sir.
Thank you, sir. Thank you, sir. Thank you. Thank you, ma'am. Bye all. Thank you. Thank you.